Hello, everyone, and welcome to this 10-minute masterclass on total intravenous anesthesia. In these 10 minutes, I will be talking about some unusual situations which are different from the usual TIVA, in which we use propofol and remifentanil in combination. The reason for choosing these three areas are firstly that this was the topic I had been allocated when we tried running some in-house teaching sessions and couldn't run those because of scheduling issues. And secondly, these are some situations where I think a lot of people lack confidence as they haven't come across these scenarios themselves. The three special situations I'm going to discuss are using propofol only for TIVA, that is, without running a second infusion alongside, using an infusion of alfentanil instead of remifentanil, and finally, using TIVA in patients who are living with obesity. For completion, I must clarify who my target audience is. Well, it is anesthetists such as yourself who are either practicing as independent practitioners in the field of anesthesia or in training, regardless of what stage of training you are in. Ideally, before trying any of these techniques, particularly the first two that I'm going to talk about, you should have a sufficient degree of proficiency in using TIVA yourself. The third topic, related to obesity, is perhaps going to be useful to you regardless of your level of experience. And finally, I must clarify my own knowledge and experience in TIVA. As many of you will already know, I use TIVA extensively across my adult clinical practice and use it for most of my patients undergoing procedures for breast cancer, breast reconstruction, and head and neck cancers and reconstructions. I try and use it wherever I can, and this includes almost every surgical specialty I happen to be working with. The main reasons I use TIVA are twofold. First, they produce a lot less nausea and vomiting, and secondly, patients wake up feeling so much better than if they'd had anesthesia with a volatile agent. Numerous studies across the years have consistently demonstrated this. Moving on now to the first of the three topics, using propofol on its own. Now, when and why might you want to use this? There are a number of advantages to using propofol on its own. You might want to do this in relatively painless procedures such as diagnostic endoscopy or radiology diagnostics. You can also combine this with a regional block for limb surgery. I often use this on patients who undergo wide local excisions of breast tumors, along with sentinel node biopsy. In these situations, I combine propofol-only TIVA with a PEX block. My practice is to administer 250 to 300 micrograms of fentanyl at induction with a further 100 to 150 micrograms towards the middle or end of the procedure. When either a mastectomy or axillary node clearance is to be performed, I don't use this method. You're better off using remifentanil for this because of both the length of the operation and the much higher stimulation involved. There are, of course, a number of advantages of using this technique. It works on the principle of less is more, saves on the cost of tubing and parts required for an additional drug to be infused alongside. You'd probably end up with a slightly faster turnover of your list as you won't need to face the issue of apnea at the end if the Remi wasn't turned off in time. And finally, and perhaps the biggest reason, it saves you and your ODP the hassle of looking for an additional TIVA pump. There are advantages. Unsurprisingly, there are also disadvantages. You'd have to be very selective in where you use this technique. If the operation went on for longer than expected, you might end up using copious amounts of propofol, which can become quite labor intensive for you, particularly if you're using 1% propofol. You may face the issue of opioid accumulation due to the pharmacokinetics of fentanyl if you are indeed using it alongside. If you're unfamiliar with this technique, you're probably better off trying it first in a setting where you're familiar with both the surgical techniques and the theatre team involved. So let's move on to alfentanil. Some of you may have used this in the context of TIVA, often mixed with propofol in the same syringe. Recently, as many of you will know, there was a nationwide shortage of remifentanil. This brought alfentanil into focus as the next best thing to use with propofol infusions for TIVA. But most of us had little to no experience of using alfentanil as infusions. As this was a national problem, even the BJA had something to say about it. Senate talked about precisely this issue. However,
Before we move on to the details of how to use alfentanil as an infusion, it is important to recall the concept of context sensitive half life. I am sure you all remember it, but pause the video for a few seconds and try and recall the definition. It is the time taken by plasma to halve the concentration of a drug after a prolonged infusion. The duration of the infusion is the context here. I have always found this to be a very interesting concept myself.
Sinead quotes a study where healthy volunteers had 3-hour infusions comparing alfentanil and remifentanil. The context-sensitive half-life of alfentanil, measured after 3 hours of infusion, was 45 minutes, and that of remifentanil was 12 minutes. Given that the next best thing to remifentanil is alfentanil, the question is, how long before the end of the operation should you turn the infusion of alfentanil off? Now, back in 1990, Jestrup conducted a study comparing TIVA with Propofol and either alfentanil or fentanyl for hysterectomies. They defined emergence time as the time interval from the end of the infusion of the anesthetic agent until the patient is able to voluntarily lift their head, and recovery time as the time interval from extubation until the patient can correctly give their date of birth. In this study, the emergence time for alfentanil was 11.5 minutes and recovery time was just 1.8 minutes. They stopped the alfentanil infusion when the surgeons closed the abdominal fascia. You can see the infusion regime that they used in this study. Bear in mind that they did not use any morphine or other long-acting opioids in this study. This study was done 12 years ago, and since then, several TCI models for alfentanil have been designed. I'm going to talk about one such model, the Scott model. Our infusion pumps have this programmed into them. To run TCI alfentanil, you need a concentration of 100 micrograms per mil of alfentanil. So if you use a 50 ml syringe, take a large ampule of alfentanil or 5,000 micrograms or 5 milligrams, whichever way you want to look at it, and make it up to 50 mils with saline, which will give you a concentration of 100 micrograms per mil. For induction, set the target plasma concentration to 250 micrograms per mil, and then for maintenance, keep between 150 and 200 nanograms per mil for most operations. Of course, you should use clinical signs and depth of field anesthesia monitoring to titrate this up or down. I suggest turning the alfentanil off a few minutes before you'd have turned remifentanil off to be in a position to have the patient spontaneously breathing by the end of the operation. It's one of those things which you will fine-tune over a period of time with practice.
In this last section of using TIVA in patients living with obesity, I'm going to largely signpost you to the SOBA website, which is the Society for Obesity and Bariatric Anesthesia, where there are a number of useful tools available to answer the conundrum which many of us find ourselves in when presented with a patient with obesity. The conundrum is, what weight should I feed into the pump? This section here provides an excellent guide on what to do in these situations. Ask yourself the question, what do you mean by ideal body weight, lean body weight, adjusted body weight, and total body weight? Once you have an understanding of these weights, it will become a lot easier for you to program TIVA pumps. I hope you found this masterclass useful. If you have any questions, please do feel free to meet me in person or email me. I will leave a list of references and my email address on the final slide. Thanks a lot. Bye bye.